So, what does other cardiovascular diseases mean? Peterson and her colleagues use this category to encompass 5 conditions. These are congenital heart disease, ischemic heart disease, cardiac valvular disease, hypertensive heart disease, and congestive heart failure. While this category does not include cardiomyopathy, preeclampsia and eclampsia, and thrombotic pulmonary or other embolism, these 5 conditions are often comorbid with other cardiovascular conditions and cause harmful interactions during or after pregnancy. During pregnancy and childbirth, a pregnant person will experience dramatic hemodynamic changes that require the heart to work harder to pump more blood to support the parent and fetus. Generally speaking, pregnant people with these underlying heart conditions are at higher risk of life-threatening pregnancy complications because they are more prone to obstructions of blood flow or cannot handle this increased pumping demand. If these conditions are not detected early on in the pregnant person's life or pregnancy, they can ultimately lead to heart attack or heart failure. To discuss these 5 conditions in greater detail, congenital heart disease is a defect in the heart that is present at birth. Its cause is uncertain, but commonly attributed to genetics or the parent's health conditions and lifestyle. Most people with congenital heart disease have successful pregnancies, but severe forms have fatal risks, which is why early detection of this condition is vital for treatment to prevent mortality. Ischemic heart disease, also known as coronary heart disease, is the narrowing of the heart's arteries. It is typically caused by cholesterol-containing deposits, known as plaque, due to one's diet. Cardiac valvular disease is damage to the heart valves, which control blood flow throughout the heart. It can be congenital or caused by age and lifestyle factors. It is associated with increased clotting and inhibits blood flow. Hypertensive heart disease refers to chronic high blood pressure that wears down the heart and reduces its ability to pump blood. Risk factors include age, race, and lifestyle, notably diet and chronic conditions. Congestive heart disease is also exacerbated over time, but this specifically refers to fluid buildup around the heart that makes it too weak or stiff to pump blood efficiently. Death can be sudden in the case of an irregular heart rhythm or after a gradual decline into organ failure and oxygen deprivation. Based on Peterson's research and the descriptions of these other cardiovascular conditions, we can identify several patterns. First, they are age-related and surface later in life. This could be because they go undiagnosed due to the lack of routine medical checkups or result due to lifestyle over time. For example, with the exception of congenital heart disease, the other 4 conditions can occur when smoking, high-fat or high-sodium diets, and prolonged stress damage the heart or block blood flow. Here, we can already see how individuals can be held accountable for their underlying heart problems. In terms of timing, they occur most commonly during pregnancy and within 42 days postpartum. This is when increased blood volume and pumping are important to the growing fetus. Compared to other causes of maternal mortality, they are number 2 in these 2 timeframes and number 3 in the later postpartum period. Overall, they are more common than other causes of maternal mortality. These conditions seem to affect pregnant people of different races at similar rates, with white women having a slightly higher rate than black women. However, Peterson and colleagues expressed that chronic diseases associated with increased risk of pregnancy-related mortality, such as hypertension, are more prevalent and less well controlled in black women. Problems that would impact women of color and working-class women, such as weathering due to repeated exposure to racism and lack of access to routine medical care for early detection of these conditions, could make them more vulnerable to maternal mortality, respectively. Early detection is important to prevent these causes of maternal mortality, alluding to issues of healthcare access. Lower-income women may also not be able to afford healthy foods, which could lead them to eat fast food commonly linked with coronary heart disease.
Confronting discrimination within the healthcare system to ensure marginalized patients receive adequate care is a necessary intervention. Prejudicial behavior can be challenged by requiring all healthcare providers to complete implicit bias training and incorporate those teachings into hospital policies. Another solution to address this unjust treatment is to create a more diverse medical staff, which would be more welcoming to patients regardless of their race, class, gender identity, immigration status, disability status, ethnicity, or sexual orientation. Not only does this provide a more comfortable setting for the patient, but it helps eliminate language barriers and prevents cultural misunderstandings that may complicate care. Develop an affordable, accessible, trauma-informed, and patient-centered healthcare system that allows pregnant patients to receive prenatal, pregnancy, and postpartum medical care without any obstructions. Improve the quality of data collection on maternal mortality to prevent future deaths and gain a better understanding of the crisis. Reducing social economic obstacles that pregnant patients may encounter by providing transportation to doctor's appointments, offering affordable or free childcare, connecting those who are experiencing food insecurity or homelessness with appropriate social services, and offering screenings for mental health conditions, substance abuse, and intimate partner violence. Doctors adhering to universally accepted mandated operating procedures for pregnancy complications. Upgrade electronic medical records to ensure accurate patient files and the ability to transmit a patient's medical history if transferring into the care of another doctor.
It is often the case with deaths that occur during pregnancy or postpartum that medical providers will shift the blame from themselves to the victims. This is definitely the case with underlying cardiovascular conditions being the cause of death during pregnancy. In order to not be held responsible for the deaths and not to be responsible for providing better care, many medical providers across states will cite the cause of death as due to the mother being under too much stress, smoking too much, having a poor diet, being overweight, or not seeking the proper prenatal care as causes for the cardiovascular condition to develop, which ultimately led to the death for these victims. According to the New York Times, a USA Today investigation found that at least 30 states have avoided scrutinizing medical care provided to mothers who died, or they haven't been studying deaths at all. Virginia state committees focused on victim blaming by releasing several reports on cancer, opioid abuse, and motor vehicle crashes as causes for the high maternal mortality rate. In Minnesota, it was recommended that pregnant women be provided more education on seatbelt use and guns in the home. The Michigan committee focused on reminding landlords to make certain homes occupied by pregnant women had working smoke detectors. Evidently, state panels were much more focused on addressing any issues that needn't be solved from changes in medical care. This deflection, however, does not address that the cardiovascular conditions, including congenital heart disease, ischemic heart disease, cardiac valvular disease, hypertensive heart disease, and congestive heart failure, were not detected until it was too late and they proved fatal. How do these issues go unnoticed? Well, often women report that they felt ignored by their provider when voicing complaints, or like a piece of meat, just there to carry a baby. The health of the fetus or baby is at the forefront of the doctor's concerns, and this puts the mother's health in jeopardy. For the most part, these women are blamed for their own deaths, even when they are under orders from their medical providers, and it is completely out of their control.
What structural drivers are missing from the discussion? First, it's important to note the labeling of these cardiovascular conditions as other. The grouping together of these conditions, a conscious process of othering 5 conditions that affect pregnant people and together contribute highly to maternal mortality, suggests a lack of knowledge and understanding that we can assume has something to do with the fact that they affect pregnant people and disproportionately pregnant people with other intersecting oppressions, whose health we do not prioritize. Medical discourse does not center around pregnant people, as this conversation is controlled and shaped historically by largely white male scholars and doctors. It's also important to understand that not only are white people usually the ones dictating research, but the ones who are being researched on. White bodies are more understood in scientific hegemony, bringing up an important point about the appearance of science and research as politically neutral, when in reality it is anything but. Here, we see a willful lack of ignorance, based on misogyny and racism in academia, at work. There is also a large question about access at play. Who has access to this knowledge? Who has access to adequate health care, entailing regular doctor visits, detection of genetic and other risk factors, regular access to OBGYNs, pre, during, and post-pregnancy care, that can diagnose, monitor, and treat these conditions? Who has access to proper nutrition to prevent some of these cardiovascular conditions? Here, we can make visible an intersection of race and class. More marginalized people are less likely to have access be it to a proper diet to prevent diabetes and high cholesterol, or to a doctor who can detect these conditions before or after giving birth. Who is more likely to have the underlying factors that contribute to these heart conditions? For example, we can look at high blood pressure, which can cause ischemic heart disease, cardiac valvular disease, and congestive heart failure. 54% of Black adults have high blood pressure compared to 46% of white adults. However, blood pressure control for people who have been recommended to take blood pressure medication is highest at 32% for white adults compared to 25% of Black adults. It's worth mentioning that there is also an issue of underdiagnosis in marginalized communities. This ties everything together. Marginalized people are more likely to have these risk factors, less likely to be diagnosed with these factors, less likely to have adequate access to structures that can reduce or diagnose these factors, less likely to be included in research around these factors, and less likely to mediate or control these risk factors when they are known to be present. This works on another level when speaking about these cardiovascular conditions, because each point also applies to them, with the understanding that these problems are occurring not only within the conditions themselves, but also within every risk factor and cause for these conditions. In summation, these oppressions work in different ways by building biases in research and society, which then reinforce these oppressions through the work or lack thereof that is done.